Hi, good morning and welcome. I'm Congresswoman Jennifer Wexton. Thanks so much for spending part of your Saturday morning with me and with my very special guest, Dr. Eric Feigl-Ding. Today we're going to talk about a very important update about COVID-19 in Virginia 10 and address some of the concerns and questions that you may have about the rise in cases and hospitalization, vaccine deployment, what the next few months have in store, and many other questions that I know you guys all have about what's going on in our district. So just very briefly, I want to talk a little bit about what's going on up on the Hill. We are in session, and I'm very encouraged because there is promising news on a COVID-19 relief deal. There was a bipartisan framework which was introduced in the Senate earlier this week, which the House and Senate leaders have indicated that they're willing to use as a starting point for discussion. And everyone has the same goal, which is to get a new round of relief out before the end of the year. We have a lot of deadlines that are going to be expiring come December 31st, so we cannot leave DC without a deal. Now, this bipartisan proposal has some very good things in it. It's got another round of paycheck protection relief for small businesses that are in need. It's got funding for the vaccine deployment and more testing. It's got more funding for the public health response, which we're really going to need in order to get this vaccine deployed throughout the nation. It's got another round of extended and enhanced unemployment benefits, more money for states and localities, and much needed rental assistance. There is a eviction moratorium that will be expiring at the end of the year, and we cannot have a homelessness crisis on top of a public health crisis, on top of an economic crisis. So that is a top priority for us. But meanwhile, we are also dealing with the effects of COVID-19 here in Virginia 10. Cases are spiking all across the district. No part of the district is immune. The Nova hospital system has more hospitalizations for COVID now than they have at any time during the pandemic. Same thing with Valley Health in the western part of the district. So this is something where, we need to remain vigilant. We need to keep up our social distancing. I know we all had a very challenging Thanksgiving, many of us just with our nuclear families. I know that was not the case for me, but it's important that we not contribute to the spread of COVID during these challenging times, especially now as the weather gets colder, more people are spending time inside, and there is clearly, a lot more danger of spread and transmission. So we have some good news, though. As you've heard, the vaccines are on their way, assuming that emergency use authorization is granted by the FDA. Governor Northam announced that Virginia is going to receive 480,000 vaccine doses by the end of December from Moderna and Pfizer. Those folks who are going to be in the first priority group are obviously frontline healthcare in long-term assisted living facilities. Those are the groups that are very much impacted by this virus, who are in the most danger. But the hope is that, and the expectation is that we'll have more vaccines coming out to the general public after that. Dr. Feigl-Ding can talk a little bit about the prioritization process and where we are on that. But Dr. Feigl-Ding, if you wanted to take a moment and introduce yourself, because you have a very impressive resume. You're an epidemiologist and health economist and adjunct senior fellow at the Federation of American Scientists, but you were previously a faculty and researcher at the Harvard Chan School of Public Health and Harvard Medical School. And my understanding is that you were the youngest person to graduate with a dual PhD degree from Harvard Medical School many, many years ago, when you were 23 years old. So clearly you have a lot of expertise in this area. If you could just talk a little bit about how you've come to, what brings you here. And another thing that so makes you so impressive to me is that you've been speaking out about the dangers of this virus since very, very early in the process, and I really want to thank you for that. So if you would just take a moment and introduce yourself.
Thank you so much. Really honored to be here. And as a fellow Northern Virginian who I live in Arlington, this epidemic is so near and dear. Especially, it's not just a Virginia situation. It's not just the U.S. It's a global issue. And as an epidemiologist, I feel like, recently I told a newspaper, watching our national leadership, it's ignoring all the science ignoring epidemiologists. They're basically, we're pounding at the cockpit door, please turn the wheel, please do something. And I think the lack of action has been extremely frustrating in terms of national leadership. And I was one of the whistleblowers about this in January, that this will be a pandemic, given what we've seen in China and elsewhere. And I think the key thing people have to realize is we've learned so much since January. The science about how it's transmitted, and what happened in the spring should have taught us a lesson, yet here we still are. And my background is an epidemiologist, but I'm more of a risk communicator. I'm trying to convince the public that to take this seriously. And the lack of messaging and leadership around taking this seriously has led to really where we are. And so where are we? The US crossed 14 million diagnosed cases. And that's actually an undercount, because we're probably underestimating cases by anywhere from 5-fold. Some people say 10-fold. In terms of deaths, we are 275,000 deaths. And many experts say we can easily have another 250,000 deaths by April, whenever the vaccines are available to the general public. So we are not out of this for quite a while. And in terms of positivity, Virginia is doing better than some places. Some places, and especially in the Midwest, are doing incredibly terribly. Their ICUs are full, their hospitals are full. We are now at 100,000 people hospitalized currently with COVID. That's higher than any time before. Our ICUs is also at a record. Deaths also at a daily record. We're almost about to break 3,000 deaths a day. It is just a terrible situation. And in certain ways, deaths, I always tell people, they're a lagging indicator. We see the cases spiking, and then the deaths, it takes about 3 weeks before they catch up, 3 to 4 weeks, depending on which state, how fast the reporting is. And so our case spike from Thanksgiving have not fully emerged, and our deaths we're seeing is only coming from November. So we have a really, really harsh winter to get through. That's why I'm really urging people to, again, it sounds like a broken record, wear masks, but also focus on things that people really haven't really focused on, and that is ventilation and air filtration. These, I think, actually the science shows are just as important, if not more important, than washing your hands, which are important, of course. But in terms of a respiratory disease, spreading it really is an airborne virus. And that's what makes it so insidious and why it has conquered the world. So it's very promising. We have vaccines on the horizon, and I'd love to talk about that more. But right now we're in a state in which it's very, very serious situation. We have epidemics upon epidemics, and we have to take this seriously together as a society.
Thank you so much, Doctor. Now it's, with it being winter, it's kind of hard to open the windows and have the ventilation everywhere, and same thing with outdoor dining and everything. I mean, that's going to be pretty challenging. So it seems like the worst is ahead of us if we don't take some active steps. So we're clearly much better at how we treat this virus than we were back in the spring. Is that correct?
Yes, absolutely. We now know how to adjust the ventilators. We now have so many more drugs. We have these boutique drugs, which unfortunately are very expensive, and drug costs is another issue in America, and health insurance is another issue. But even if you have them, they're quite difficult to access or even afford. Like, for example, there's convalescent plasma, which are very limited, and these synthetic antibodies and monoclonal antibodies that Trump and others have used, they're also very limited. So we are better, yes, but I also want to remind people that if we don't have hospital beds and ICU beds and the doctors and nurses to staff them, which is a serious situation right now in the Midwest, without enough doctors and nurses for the hospital beds, even if you had more beds, we're not going to be able to lower the mortality. That if the hospital beds are full and there's no more doctors and nurses and no more ventilators or ECMO machines, then deaths will surge even more. And in certain ways, it's good we have treatments, but some leaders basically say, well, as long as we have more beds, then we're fine. That doesn't mean it's almost like an abdication of duty in which, well, we have hospital beds free. We don't need to have drunk driving laws. We have hospital beds free. We don't need to have gun safety laws. We have hospital beds free. We don't need seatbelt laws or bike helmet laws. And that's just not the right attitude for public health. Because truly, I tell people, you can't just hope that once we get to less than 5% positivity or 3%, New York City sets 3%, it's not like businesses will flourish all back again. Because if this was Jurassic Park and there's a few velociraptors roaming around, no one's going to go to the park. Well, if you have a zoo and there's a mountain lion, just one in a big zoo, moms and dads are not going to bring their kids to the zoo. And that's the thing. Until we actually have the virus fully under control, businesses are not going to flourish. No one likes lockdowns, but businesses are not going to flourish until we actually fully contain this virus. And this is why it takes collective action to do so, not just, as long as people are not dying, as long as we still have hospital beds. That is the wrong approach. And I see that in many governors around the country who are just neglecting so many things, from mask mandates and whatnot, just because they still have hospital beds free. So I really hope we can turn this around in the coming months before the vaccine comes.
That makes two of us and many, many more of us as well. So I do want to ask you a very quick question about vaccines. I know a lot of people submitted questions about vaccines, and there will be more specific ones. But can you speak very briefly about what the process is for the approval and everything? Because my understanding is that there are a number of different drug companies that are working on different vaccines on parallel tracks. And what is where are we in those phases of the process?
Right.
And what kind of timeline are we looking at?
Right. There's dozens of vaccines in the clinical trial pipeline, but only a very few are in the final stages of the phase 3. The phase 3 is when they test it in 30, 40, 50,000 people. And that's the Pfizer, Moderna, AstraZeneca vaccines that have successfully completed the early phases of phase 3. And we're seeing the results. And the results currently show that the Pfizer vaccine is 95% efficacious, as in, if you give the vaccine to 100 people, the vaccine lowers the infection rate compared to placebo by 95%. And it also protects them.
That's pretty encouraging. It's good.
That is encouraging. But at the same time, 1 out of 20 still get infected in certain ways, because 5%, 1 out of 20. And if you say in the 1 out of 20, do you want to roll a dice with 1 out of 20? It is not the panacea that we foresee it is. And the other key thing is, it's not the vaccines that save lives, it's the vaccine programs, vaccine rollout. And that's why leaders like you and Congress and governors are so critical, because our public messaging, our public policies, our laws, our incentives, our enforcement and regulations to encourage people to vaccinate is so critical. Because if you have 100% efficacious vaccine, but 50% of people don't take it, you have a 50% effective vaccine. And the worry is right now, of course, there's a lot of hesitancy. We have to get people over this hesitancy. And the clinical trials clearly show it's 95% efficacious for the Pfizer, 94% for the Moderna, and 70 to 90% efficacious for the AstraZeneca Oxford one. And they're going to do it again just to prove that it does further work for the AstraZeneca Oxford one. But it's the rollout, because each of these 3 vaccines require 2 doses. Dose 1, and then 4 weeks later, approximately, a second dose. And in certain ways, that actually makes it even more difficult. Now, in the US, the cold chain issues is less of a problem. That it needs negative 70 degree, basically dry ice temperature freezing, and regular freezer for the Moderna one, negative 70 for the Pfizer one. But this is a much more difficult problem outside the US with that kind of free and cold chain requirement. But again,
not a cake in the US either, though, to be able to have
I know it is not easy. It is not easy.
Difficulty for sure.
I think for healthcare workers, it's easy because hospitals have that kind of freezer. Mm-hmm. But in the general lay community, it'll be hard. But my biggest worry is that when people right now don't even take their medicines on a regular schedule oftentimes. And we know from previous hepatitis vaccines, you're supposed to get your booster. Only 10% of the people got their booster shot within 1 year as recommended. And we have to get this booster within 1 month of their first one. So we need a very clear, effective rollout, preferably some incentives, and that's for legislation to decide. I personally prefer if there was actually some legislation for some financial payout for people to take the vaccine as well. But getting that second dose is so critical because we have a very disjointed healthcare system. If you see a doctor at Walgreens or CVS, it's not tied in with your medical records anywhere else. And getting people vaccinated and reminding them to come back in 28 days, there's a lot of challenges in that. And so it'll take a really national effort.
That you have a vaccine available, a dose of vaccine available, and that's the same one. So I know there's a lot of other questions. So I'm going to toss it to our support to come up with, to ask some of those questions from our viewers.
Great, thanks so much, Congresswoman and Dr. Feigl-Ding. So our first constituent question here is from Mary from Western Loudoun, and she asks, how are local hospitals coping? Are they overloaded and or facing staff shortages?
So I'll start with this one, and then I'll toss to you, Dr. Feigl-Ding. I have a regular phone call with the local health departments and hospital systems, and across our region, and I know we're not alone in this, they have set records for their COVID positive patients at this time. I think that Inova has 100 and almost 200 across the system, and same thing, Valley Health has the highest they've ever had. And in talking with Secretary Carey, the Commonwealth's Secretary of Health and Human Services, he has indicated that the real concern, we're okay on bed space right now. We're in a better place than a lot of other states. But they still want people to be vigilant because it's not just about the beds, it's also about the staff, because they really are very fearful about staffing shortages because, these people have been going full tilt for so long that a lot of them are experiencing burnout. And there's so much competition also for skilled nurses, respiratory techs, ER doctors across hospital systems. It's very expensive to hire new people. There aren't any available. And so the staffing shortages is the thing that they're most fearful of. But I'll toss it to Dr. Feigl-Ding to see what else he's heard around the nation here in Virginia.
Right. And the hospitalization is becoming the staffing. I always tell people the staffing is actually harder than the beds. You can always add more vents, add more beds, but to staff them properly is really key. And if you don't staff them properly, it's equivalent to having a gurney in a hallway, effectively. And right now also, by the way, the skilled nursing are in such high demand that there's bidding wars for nurses anywhere from $6,000 to $10,000 a week if you're willing to travel to some more of the hot spots, which actually bleeds away staffing from other places. But Virginia obviously is doing still a little bit better than some other areas. We have a lot more hospital staffing than other places. But I want to remind people, in the worst hit places like North Dakota or Italy, doctors were in Belgium, they've been asked to actually work even while COVID positive, because we have a PPE shortage here, in the US, in which doctors are reusing N95 masks, and not all the nurses and respiratory techs have N95, sufficient N95 masks. And if they get sick,
Looks like Dr. Feigl-Ding is getting frozen. I'm not sure if, Justin, are you there?
Yes, it does look like he's frozen. Give me 1 second. I can touch base with him.
Okay.
I'm getting him back in. But in the meantime, I think we can hop to another question here.
then the whole system collapses.
Dr. Feigl-Ding, I'm sorry, we lost you for a minute there. So.
Okay, great. I'm back.
Okay, we can move on to the next question. You can hear us.
Sure, great. So we have a couple questions here about vaccines. Betsy from McLean would like to know how we know when and where we can get the vaccine. Essentially, where is my place in line?
I think for vaccines, oh, I hear an echo. Sorry.
Let's go ahead while Dr. Feigl-Ding gets his audio adjusted. You know, a lot of that is still being determined. ANOVA is one of those hospital systems that has the deep freeze. There are 16 hospital systems across Virginia that have the freezer capacity for the deep freeze vaccines that need to be deployed. But a lot of you know, that first round is going to be healthcare work, frontline healthcare workers, and those in assisted living, those really vulnerable folks who were decimated by this virus. And there's about 500,000 of them here in Virginia with our population of about 8 million. So it's going to take a while to get all of them vaccinated. I guess the question that I have also is, are we going to ensure that all those people receive both doses of their vaccine before we start the next round of the people who have pre-existing conditions that make them, you know, comorbidities that make them more vulnerable, or elderly folks who are also significantly at risk. So that's something that's a great concern for me. Also in Congress, you know, that's going to take money to deploy these vaccines. We all are aware of that. And right now, states and localities don't have it. It's going to fall a lot to the local health departments to get this vaccine out the door. And so that's why we are so adamant to get a new stimulus package done before the end of the year, so that states and localities and health departments have the resources that they need to be able to deploy this vaccine as soon as it's available. But Dr. Feigl-Ding, I'll pass to you to answer anything else about that.
Yeah, the vaccine rollout is just so critical of an issue. I want to emphasize that you know, we're trying to first give it to healthcare workers, and then essential workers, which is about 87 million people designated by Homeland Security as essential. Although yesterday the American Bankers Association tried to add Wall Street bankers and financial workers as part of the essential workers, and that was a very controversial move. But I think by the time we do the rollout, it will be about April until the general public. I think between high-risk factors come after the essential workers. And so by the time we get to the general public, hopefully April, anyone who wants a vaccine can get a vaccine. But then it becomes this incentive issue of, can we incentivize enough people to get it? Because how many people do we need vaccinated? Optimally, at least 80%. Some people say, well, I've already been infected. You should still get vaccinated again. Some people say, well, we need, you know, I'm not sure if if this is safe, and all these kind of conspiracy groups, we have to convince them to take it. And I think in certain ways, there's also this discussion of, will we require it for people to go back to school? And will we be able to do it fast enough that our kids can go back to school by midway through next spring? Or will it be until the fall, until we finally are reliable enough to go back to school? Because I do not want any kids to be out of school until January 2022. I think everyone shares that.
I think you speak for everybody when you say that. I know that I don't want that to happen, and then none of my constituents do either. So that actually gives me two quick follow-up questions I want to ask before we get to the next one. First one is, do all the vaccines require 2 doses to be fully efficacious?
Not all. I'm really hopeful for the Johnson & Johnson vaccine. The Johnson & Johnson vaccine is still not finished yet, but the trial was started about 2 months ago or 1.5 months ago. So hopefully that one will come out soon. The beauty of the Johnson & Johnson is a single dose vaccine. Hopefully it's just as efficacious, and it does not require any freezing. A simple refrigerator is sufficient and it's stable for many, many months. So in many ways, I personally think a single dose will make the logistics around vaccine rollout 10 times easier, especially if it also doesn't require freezing. And that one, it might be a little bit later than the initial ones that we start with, but I'm very hopeful. And honestly, even if it's 70% effective, I would take that, because a 70% effective vaccine is way better than no vaccine whatsoever. And I also want to remind people, having a vaccine actually gives you greater protection than if you had natural infection. We've already seen that many times. So this is, again, another reason not to chase the herd immunity plow-through approach to get everyone naturally infected. Herd immunity is only something that we talk about in vaccines, where once you vaccinate 80% or more, then the rest of the population is also protected as well. So let's really hope that we can have these other vaccines also coming up from the pipeline soon.
I did not know that having the vaccine was more effective than the natural antibodies that you had from getting infected previously. That's good to know. And then another quick question I had was that have any of these vaccine trials had children as the subjects of these trials, or have any of them? Do we know whether these will be approved for children or not?
Yeah, they were tested in adults. And that's the children's pediatric testing will take longer. And so this is why it's so critical that we, again, vaccinate ourselves so we actually reduce transmission to children. And children are not immune, as many people claim. Granted, children transmit it much less, but teenagers are basically effectively young adults. And it's young adults who spread it the most. So we need to vaccinate also to protect our kids and also protect our teachers at the same time. So in certain ways, there's another argument. We should vaccinate young people faster than some of the elderly, because this is the counter argument, because it's young people we know that actually spread the virus way more. They don't get as sick and hospitalized and die as much. They do, but they spread it way exponentially more than, say, an elderly person in a nursing home. So this is why even if you think you're healthy, you still need to get vaccinated. And this is why the rollout is just so important.
Thank you. Justin, do you have another question from the audience?
I do. I actually, since we're on the topic of vaccines, have one that was submitted on YouTube from Sarah, and she would like to know, how would we be notified that we are eligible for the vaccine?
Could you repeat the question?
How will we be notified that we're eligible for the vaccine?
I think the eligibility of a vaccine is based on your qualifications in these different categories. So there's actually a New York Times calculator based on your age and your risk factors and your occupation, and it'll tell you where you are in the priority line. If you are, say, I had a friend who was a journalist. If you're a journalist or you're one of those, municipal workers, you immediately jump ahead of the line than if you're someone who working a regular white collar job. But also it depends on your risk factors. But in terms of the morbidity, we actually don't have a system. I welcome your thoughts about this, because I think it's based on proof of your age and your morbidities. If you have diabetes or heart disease, then you qualify for the next tier after essential workers. But we actually don't have a national system set up, because unlike many other countries, we have no national healthcare system that can directly assign people based on some risk score that you're next. So I think we have a very unstable rollout in that sense, beyond the occupational and age requirements.
I think that the age requirements are going to be easy, obviously, to ascertain because you ask people for ID. But the comorbidity or the pre-existing condition thing is going to be a lot more difficult, because, as you point out, we're not going to have that. And it's not like you're going to go to your regular doctor and get this vaccine unless and until we have that one dose stable kind, which gets widely distributed. So I think a lot of it's going to rely on self-reporting and the honor system. I mean, in order to be rolled out properly. But that's an excellent point. I hadn't thought about that, how we were going to do that. So it's going to be challenging.
All right. Our next question here comes from Greg from Sudley Springs, and he asks, what is the benchmark when we stop wearing masks and have zero restrictions, or does this go on forever? Do we take a vote, 0 new cases dropping below X point when Joe Biden is inaugurated? The COVID is out of the bottle. It is here to stay. Does that mean the mask and restrictions are here forever also?
Well, I know it's not going to be, I don't think it's going to be forever. I know it's not going to be forever. Let me put it that way. And I know it's also not going to be, it's going to be sometime between 100 days after when Joe Biden is inaugurated and forever. Because I know that we need to get these vaccines deployed. And my understanding is that the president-elect has just indicated that he's going to ask Americans to mask up for 100 days in order to get this under control and give us an opportunity to get those vaccines deployed and out the door. But, and even when you're vaccinated, as Dr. Feigl-Ding pointed out, you're not 100% protected. So I think that we're going to have to wear masks and do the social distancing for quite a while until we get enough herd immunity or enough really getting the virus under control. But I'll toss to you, Dr. Feigl-Ding, because it's
really much kind of like a break.
It's going to be more a matter of what the public health experts say. So I'm sorry.
No. I think it's a combination of when you let go of the gas and put on the brakes, and when you let go of the brakes, you're not going to immediately accelerate to completely without any restrictions back to normal again. It's based on a tiered system of depending on how many people get vaccinated, how quickly. We've actually done a math calculation that if the world has a fast rollout, we'll gain $3 trillion the world economy by reopening faster. If we have a slow rollout, we'll lose $4 trillion. It's a net difference of $7 trillion, according to the OECD. And so if we roll out and there's very fast uptake, very fast compliance of all these, and the cases will immediately start dropping. I guarantee it. But it's how low will we drop? Because this gets into is 5% positivity low enough that we can just ignore every public health containment measure again? I'm not sure about that. I think in certain ways, we need to make sure that this virus goes to 0 before we lift everything. Because look, all these other countries, in Australia, in New Zealand, they're having soccer matches with 50, 100,000 persons filled stadiums. We can't do anything like that right now. There's big mosh pits concerts in other countries right now that have contained them down to 0 COVID. And that's what we want, our lives to get back to normal. So in certain ways, as soon as the vaccines roll out are successful, because it's vaccination programs that save lives, then we can ramp up to hopefully 0, ramp down the other mask wearing and distancing. But until then, we don't have a set answer. It's a moving target of how quickly we get this vaccination rolled out.
And we haven't had universal masking in this country anywhere at any time. So what are the statistics say? What do the public health statistics say about if 95% of people wore masks or things like that? What would that do to the transmission? Just if
we have 95%, we can contain this. Look, if we had 95% mask wearing, we wouldn't even need vaccinations to bring it down to control. Because look, all these countries in Australia, New Zealand, Taiwan, China, and Vietnam, they basically have almost 0 COVID without a vaccine. But we're just at this stage, obviously, with the mask wars. And my worry that the anti-maskers now are going to be anti-vaxxers in next year once that ramps up. And I hope it doesn't devolve into that situation. But if you have cloth masks, 95% people wear them, then it works. My worry is that oftentimes there's a lot of communities that don't wear masks and they're like 50-60% mask wearing. Then in certain ways, cloth masks are not enough because cloth masks protects others around you. But if others around you are not wearing them, you may have to switch to more premium masks like surgical masks, KN95 masks, which, by the way, many other countries offer their citizens for free. But we thought about mailing masks. We thought about mass production of these premium masks, but we never got to that place. And hopefully, maybe Biden administration would invoke the Defense Production Act for these premium masks. But the faster we roll them out for the masks, in addition to the vaccines, the faster we can contain it. They all add up cumulatively to stopping the virus.
Thanks, Doctor.
Our next question here, we actually have two on this next subject. The first comes from Georgia from Winchester. And Georgia asks, how can you possibly know the truth of this virus? We've been deceived from the beginning with false science and panic-driven media, which you participate in. So the question is, how can you possibly get accurate information when a smokescreen has been put up to misinform people? And second question, Christopher from Leesburg, on the same subject, what proven effective steps are being taken to combat the mistaken belief that COVID-19 is not dangerous?
Wow, this is a study in contrast to what we're actually dealing with in terms of misinformation and this whole information wars about this virus. I mean, you cannot argue with the fact that over 270,000 Americans have died as a result of this virus, and over 10 million have been infected. It is something that has changed our lives dramatically. And I know we don't like it, but denying it doesn't make it go away. It just gives it strength and gives it more force. This is something, the disinformation surrounding this virus is something that's been very concerning to me and a number of people in Congress. And that's why I introduced legislation for a study to combat COVID disinformation and misinformation. And Dr. Feigl-Ding, I know that you've been fighting against this disinformation campaign for quite a while. Yeah. So I'll toss it to you to talk about it a little bit.
Yeah, I feel like this misinformation is just as dangerous as, if not more dangerous than the election misinformation and disinformation campaigns of 2016. And, we've actually, at Federation of American Scientists, where I'm a senior fellow, we've actually studied this, and half the people who are tweeting about pro-herd, the Scott Atlas pro-herd immunity, half of all the accounts on Twitter tweeting about that are actually bots. And so there's incredible amounts of misinformation. And of course, there's the 6% theory where, only 6% of the people had no other risk factors. And if they had other risk factors, they died of something else. That conspiracy obviously is completely bunk. And I think the most dangerous is the one that's attacking doctors and nurses, which says, they're overbilling just for money. If you look at any hospital or ICU right now, the doctors and nurses are completely overworked, burnt out. There are no more beds. If you have a car accident for any other thing or have a stroke for any other reason, you are basically perhaps out of luck when getting a hospital bed. My worry going forward is this. If we're going to vaccinate 10 million people in the next month, or, obviously we're going to aim for a much more, 100 million, 200 million people later on, there are going to be people who took the vaccine and will have died because just naturally over the next 2 months, just among 10 million people who get the initial vaccines, there will be 14,000 people who died. And I think what was worrisome is that some of them will blame the vaccine, even though on average, with 10 million Americans, you're going to have 14,000 people who die over 2 months. And that is my worry, because how this vaccine was rolled out, how the misinformation is spread, my father or my mother took this vaccine and they died, whenever there's 14,000 that will die naturally over the next 2 months anyways, that is actually the big fight that I'm worried about, because that misinformation engines will completely beat that horse to try to, spread basically confusion. And these are the things in which, the vaccine programs and the public health initiatives around this is so much more than just the science of vaccines. It's the public policies we engage in for a better healthcare system, more healthcare affordability and transparency, as well as structures of building trust to defeat vaccine misinformation. And so this is why I think Congress has a great role, and I really appreciate Congressman Wexton leading that effort.
So, and I share your concerns, and I had heard the same thing, that so much of this disinformation is being driven by bots and being driven by bad actors. And I think the social media companies are trying to do what they can, but they have a lot more work to do to combat it. And I don't know that putting a label on something is the same as taking it down, especially if it's a bot.
Yeah.
So hopefully they'll step up and do their part to cut back on a lot of this disinformation that's out there.
Great. Our next question comes from Glenn from Fairfax, and Glenn asks, why are COVID cases increasing if no recent changes were implemented in state policy?
So I'm not sure. I know that we haven't implemented a lot of changes in our state policy, but I think a lot of it can be attributed to COVID fatigue and people letting their guard down. As I mentioned, I have these regular calls with our local health departments, and most of what they have seen in terms of the outbreaks in this region, in Virginia-10, is not because of big gatherings. It's because of things like the workplace lunchroom, where people, will take off their masks and congregate, or carpools where they feel like they're safe because they're with a group of people, or these social pods, which actually have intersecting Venn diagrams of people who they think that they're the only people that they're socializing with, but they're going out and socializing with others. So it's more a lot of small things where we're all tired of the restrictions. We all want to get back to life as normal, but we can't. And some people are letting their guard down, and that's my understanding is where most of our increases in Virginia are coming from. Also, it has spread everywhere. So, early in the pandemic, it was mostly Northern Virginia and Hampton Roads that were dealing with most of the cases. And now Southwest Virginia has a much higher positivity rate than the rest of Virginia, and is really suffering very great damage and a lot of increases in their cases, and their hospital systems are much more stressed than ours here in Northern Virginia. So that's what I have seen, but I'll toss it to Dr. Feigl-Ding to say what he has seen from the data.
Yeah, I concur. I really think it's oftentimes people have this very innocent view that, oh, I'm in a pod, but I can see one friend, but then everyone sees another friend. There's a saying back in the old days of the HIV epidemic that if you don't use a condom, you're basically sleeping with everyone that person else has also slept with. And in certain ways, this intersecting pod thing, especially for infectious virus, has that similar analogy. And Cuomo today actually also pointed out, and he's correct, it's oftentimes small gatherings now, because we've basically prevented most of the large gatherings, these big weddings and big concerts and big nightclubs, but it's these small family gatherings and small friends that they get together. They feel very awkward about telling someone, a guest in their house, to wear a mask, just not to mention take off their shoes or something like that. You know how awkward it is telling a guest to take off their shoes. To make a guest wear a mask and open windows, it's incredibly difficult. And this is how it's spreading from this small social network kind of bubbles. And this dining issue, indoor dining, is just exacerbating it for the most part for the longest time. Whenever there's no such thing as distancing or mask wearing when it comes to dining in bars. And so in certain ways, it's really frustrating because we're sacrificing our children's future by keeping the bars and restaurants open. And I personally feel like we should actually have a bailout system for some of these businesses so that we can actually have schools reopen. And I think in certain ways, I hope if national leaders don't do it, state leaders invoke and pre-purchase rapid testing. If we have these rapid testing that gives results in 10, 15 minutes to millions of households, I think actually we can control the virus even faster. But obviously this requires a lot of leadership and coordination on a level beyond just our communities. But for your local communities, I feel the main thing is avoid small gatherings, even if you're doing everything else right in the public, mask wearing, distancing, because it's always when we let our guards down at home that the virus spreads.
And I share your concerns, Dr. Feigl-Ding, about the indoor dining, and that's one of the reasons that we incorporated the Restaurants Act, which had targeted relief for small independent restaurants into HEROES 2.0 to make sure that they get that relief. And my understanding is that this next round of stimulus talks, that they're talking about targeted relief in the Paycheck Protection Program, which would go to a lot of those really hardest hit businesses, not the ones that don't need it, which unfortunately was something that happened with some of the first rounds. Yeah. So thanks.
All right, we got a lot of questions about vaccines, so I'm going to run through a couple of them actually, and then we'll let the Congressman Dr. Feigl-Ding answer. First one here is, my concern is with the new vaccines. If you receive the vaccine and you are exposed to a mutation of that virus, how does that affect how your body will respond to the mutated virus? Next one here, again, a vaccine-related question. When a person gets both shots of a COVID vaccine early in the game, when the majority of people have not been vaccinated, can he or she assume that the possibility of contracting the virus is low, even if herd immunity has not been accomplished? And then finally, last one here, with there being 4 main types of COVID vaccines, what, if any, information is available about taking multiple vaccines of different types? And how will doctors and patients decide which vaccine type to prescribe or take?
So I don't even play a doctor on TV, so I think I'm going to toss to Dr. Feigl-Ding for most of these. But I will say, as far as the deployment of the vaccine and which one you're going to get, I think a lot of it is just which one is the easiest to deploy in your region and which one gets sent to you and where you are in the queue. Because I think we're all just going to get whatever is the next available. But I will toss to Dr. Feigl-Ding for all those questions.
These are really good questions. And I think these are questions everyone asks. So first of all, I don't think you should take multiple, especially when we don't even have enough for everyone. I think that multiple question is not on the horizon yet. In terms of protection, yes, if you get vaccinated, and you get a basically immunity built up to it, then you become a dead end for the virus. And it's possible that you still carry very low amounts of viral load, but it's probably not enough to make you sick, as we've seen. For severe cases with the Pfizer vaccine, it's 100% efficacy in preventing all severe cases so far. But basically, you become a dead end to the virus, and that's how herd immunity is supposed to work with vaccines. Herd immunity means if, say, you have the virus, I don't, but we're in a crowded room, but everyone in the middle of the crowded room has the vaccine, they become a wall against them, someone else transmitting it to you, even if you don't have it. So yes, a vaccine makes it mostly virtually makes you a wall against the protection against transmitting it. And the mutation question, I would say I'm pretty confident that mutations will not affect the vaccine, or extremely unlikely, because mutations can happen everywhere. But we would have to be extremely unlucky in having the mutation happen in the spike protein. The spike protein is the protein that latches from this virus onto human cells and then enters the human cell. So unless it's something that happens in the spike protein right where the vaccine is training, it's probably not going to affect it. That said, it could happen, but very unlikely. We have not seen it yet. And this is also why it's good to have many different vaccines. There's dozens of vaccines in phase 3. There's actually way more in development. But the 10 vaccine in phase 3, the more diversity there are, the better. Because if the mutation affects one vaccine, then another vaccine could still work. So this is why we need a collective effort. And this is why the US should join COVAX, the WHO consortium for sharing vaccines, making sure it's available to the whole world. Because, we shouldn't be America first when it comes to this vaccine eventually. We should consider that if it doesn't control, the virus is not controlled throughout the world, it's going to come back and bite us. And until the whole world has this virus under control, we're never going to get back to fully normal. So it's in our interest as human civilization to share as much as we can to make sure that happens.
And how about how we are going to decide, which of the vaccines that are available, which one we're going to take? I mean, how much of that do you think we're going to have discretion over, or healthcare professionals will have discretion over?
Yeah, I don't think we have discretion early on. I think early on, we've pre-purchased already the Pfizer and the Moderna, and Pfizer, they're already being positioned as we speak. So once it's FDA approved, hopefully after the December 10th meeting, that within maybe a few days or a week after, we'll be able to give it out because they've already been pre-positioned. So at the beginning, it's whatever we have in stock. But I think later on in the spring, once the availability is wide enough, then we'll have more data to see, well, maybe among older people, the Pfizer is better. Maybe in younger people, the AstraZeneca one is better. And those things require a lot more data. So as we go along, I think we'll be able to make a better decision once the spring comes and availability is wider.
Great, thank you.
Next question here is also on the topic of vaccines, and it comes from a comment on our live stream. This individual asks, is someone who's received the first dose of the vaccine but not the second more vulnerable before having the second dose? Do we know anything about that yet?
That's a good question. So are they more vulnerable than they would be if they hadn't taken any at all, I guess?
Well, yeah, I think having one, so I've looked at the curves. The second dose is definitely a booster for the first. So the first one gives you around, there's a wide variability, around 67, 70%. And then the second dose puts you at the highest level. So obviously one dose is better than none, but 2 doses is better than 1. And I think that's what we've been finding. This is why it's a 2-dose vaccine. So again, the more we can make sure that everyone gets both doses, the better. And so far, in the latest data shows those who have gotten 2 doses, their immunity has been pretty good for the full 3 months of follow-up that we do have. So I'm hopeful. But again, definitely take any dose that you have, but 2 doses is definitely better than 1 dose, especially for you being a wall against transmission to others, which is the main goal of the vaccine, in addition to protecting yourself.
And how long is the recommended period of time between that initial dose and the booster?
About 4 weeks, about 28 days. That's in the trials. That's when they delay.
If you go a little bit beyond the 28 days, would it still be efficacious, or would it?
We don't know. We don't know. Like we've seen, especially in the real world, when it comes to hepatitis, you're supposed to get the second dose within 6 months to 12 months. Oftentimes people get it after 12 months. It becomes this real world situation where we don't know what is the optimal. Maybe 3 weeks is better. Maybe 5 weeks is better. But on average, we tested it at 4 based on our previous experiences. So 4 is
that tightly controlled environment for their testing, and that's the only thing that we know right now.
Yeah, we're developing this. We had to make lots of guesses at the beginning. We think the booster definitely helps. That's what we discovered in phase 1 and phase 2, right? And so because we know the booster helps, well, when should it be? Well, based on vaccine technology and experience with other vaccines, we decided 28 days later. So that's how it was decided. But we will find out more if the booster works better at a later date. But again, we're on a very tight horizon, and this is the best system and regimen that we've discovered so far.
Yeah, I mean, it is remarkable how quickly they've managed to get these vaccines, created and tested and through the protocols and the phases of the process.
It's very difficult to do it so quickly.
Our next question here is another one from the live stream, and they ask, what did these other countries do to reopen with mass gatherings? What are we missing?
Dr. Feigl-Ding.
Yeah, this is a really good question. And basically, in other words, what did we do wrong? I think it's a social commitment, trust in government, that when government says everyone locked down, stay at home, that they had very good compliance in many ways. Whether it's mask, stay at home, and we have so many states in which we have this loosey-goosey lockdown and then 2-3 pages of exemptions. I think this is why social solidarity really matters. But beyond this kind of social solidarity trust issue, and of course the mask wearing, where they assumed that it was an airborne virus from the very beginning. We didn't recognize airborne virus and put the airborne guidelines until much later. Japan, a lot of these Asian countries assumed it was airborne from the beginning. Testing, contact tracing, and quarantine. That's traditionally how you stop a virus, an epidemic. But the testing, we were very late. The CDC did not roll out its testing kits for labs across the country. The FDA did not approve tests for quite a while. And the contact tracing in certain ways in Korea, when they had the nightclub outbreak, first of all, Korea has everyone's mobile apps are very much monitored it's part of the contact tracing. Virginia has an app now too. But Korea went further. When there was a nightclub outbreak, they collected every single credit card transaction in that local area and everyone's cell phone SIM card. If you had touched the local SIM card tower, they basically found you by your cell phone and texted you and basically tested everyone in that area. We don't have that capability. And the quarantine, many countries like Taiwan actually paid for people. I will pay you to stay quarantined. I will pay for your hotel, pay for your lost wages. And we don't have that kind of protection. If you're a waiter or waitress or any hourly worker here and you test positive, you're out of a job for 2 weeks. Your friends who are in your close contacts are out of a job for 2 weeks if they're also close contact. And so people didn't want to get tested. People didn't want to stay home. But in these other countries, they paid people to stay home. And in many other countries with lockdowns in Europe, they paid every worker 80% of their wages. Basically, paid either the company directly or paid to the workers themselves, and paid to the companies, compensated them 70, 80% of your last year's earning this month. We will directly compensate you to make sure people stay compliant, people stay home with the quarantine, and again, that they are willing to report and answer contact tracing. So all these kind of things we did not have. We did not build the social structure to support. And this is, in certain ways, an argument for basic income, guaranteed, minimum wage, and income protection for people who are out of work because of illnesses. All these things are so fundamental, and all these things are decided in Congress. And that's why it's so important to fight for healthcare protection as well as worker protection on top of all this.
Absolutely, Dr. Feigl-Ding, and thank you so much for really your strong support for these programs. And that's something that we have here in the U.S. that we're lacking, is a strong social safety net. And we had some good things that came out of the CARES Act with the Paycheck Protection Program and the enhanced unemployment benefits that we had for a period of time. But the problem was that we didn't really, on the other side, take all the public health measures and steps that we needed to during that period of initial shutdown. So, part of it is that we also have a federal system in this country. So we had state by state this patchwork of rules and regulations, whether it's with different states and different localities. And a lot of it also is the whole idea of individual freedoms versus sacrifice for the collective good. And a lot of other countries are willing to make that sacrifice. And unfortunately here in the US, few people are. So too few people are, and that's what we end up with. is a lot of people for the cause of freedom endangering themselves and making this and others and making this pandemic a lot worse than it had to be. I cannot ignore the fact that there was really very little leadership and modeling from the top. I hope that we have gotten past that now, and that we're able to turn a page, and that we'll see some real improvement in the future. But on that note, I see that we've already hit our hour. Dr. Feigl-Ding, thank you so much for joining us today. I learned a ton. I hope you guys did too. I know that a lot of you had questions that we didn't get to. So if you did submit a question that you didn't get an answer for, we will try to reply to everybody by email. And if you have questions about other things that are constituent service related, things like unemployment benefits or small business questions, please do not hesitate to reach out to my office if there's anything we can do to help you at wexton.house.gov. Dr. Feigl-Ding, do you have any last words that you want to share, last words of wisdom or thoughts that you want to share with our audience before we send them on their way?
Thank you so much for hosting this event. And I think, stopping the epidemic starts with each and every one of us. It's all these personal decisions that makes a huge difference. So please don't let up, stay safe. Christmas, if we don't have a full Christmas this year, we will want to celebrate Christmas with our friends and family next year by protecting them this year. And I think that's hopefully we're not canceling Christmas. We're saving our friends and family for future Christmases. So I think that's so key. And thank you so much for your work on the Hill to make sure we get the second coronavirus stimulus. So many people need the help. So thank you so much.
Thank you so much for joining us today. And those words are so wise. We all have the power to make this better. So we have the power, but we also have the obligation. So there is light at the end of the tunnel. So be patient, keep up the social distancing, keep up the masking and the hand hygiene, and stay safe, everybody. Thanks so much. See you soon.